कोई पार्सल मंगाया करें 1950
लेकिन हम बिजी हैं, बाद में बात करें।
So we are on live, sir. You can start off. Thank you.
Good afternoon, friends. At this prestigious platform of IJCP Publications and my revered friend and my mentor and my colleague and a best person in my life, Dr. K.K. Agarwal, my salutations to him and his family is maintaining it. His son is not with us. He's attending an API conference, I'm told. So how far we have gone in COVID, this is the topic for today. Let me belatedly wish all the viewers and listeners a very happy belated Independence Day. It actually goes for 3 days, so we can wish it today also. This COVID has been ruining us for past 2.5 years, rather 3 years now. And we have traveled through enormous journeys in the various parts of the world. And the end result is suffering and suffering. Many variants have come so far, and they have almost occupied the lineages in the various categories. And all these letters starting from alpha, beta, gamma, kappa, lambda, and then alphabets like BQ1 and BA5. And these are the recently talked mutants. And BQ 1.1 out of them carries an additional spike mutation, which was a relatively recent viral subgroup and kind of variant. And in a key antigenic site, that is R3460 and epidemiological week 43 to 9 October, this was isolated from the sequence submitted in the GSAT BQ1 and has a prevalence of 6%. This is like, it has become a history now. Similarly, variants like BF7 is a sublineage of Omicron variant. This was considered to be highly transmissible and reinfections rates were seen high. R factor was also high and so on. And they said that antibodies from the vaccination are not effective enough against the virus. Here, I would have a word of caution. Our vaccines, Covishield and Covaxin, have not shown this. The other vaccines like American vaccine, RNA vaccine, mRNA vaccine, and Pfizer vaccine, they have deficiencies and which are open now to everyone. It's no more a secret. So our vaccines, including nasal vaccines I'm going to talk about, would be the best for the future also. Now, China is again witnessing wave. We can't say wave, it's like a big numbers. And it's a very heavy infection in China. And thousands and thousands of people are dying. I'm not quoting any statistics because all statistics coming from China are wrong. I have one reliable statistics that now China's population has dropped down. I would say maybe I don't have confirmatory statistics, but dropped down lesser than India. This is unconfirmed reports. These variants are many and they are recirculating in China. They have already traveled India, so we have no danger. And these are all variants detected in the countries. where vaccination was not that successful. They have gone for American vaccination, Pfizer vaccination, and they did not have indigenous vaccines. Like Germany, Belgium, France, Denmark, US, and UK, they are suffering a lot still. Now, the symptoms which we have to watch, some of the symptoms have changed, like from normal coryza, upper respiratory like illness, runny nose, fever, sore throat, cough. These were the classical symptoms. We added later that loss of taste, loss of smell, that also has gone past. Now we have diarrhea, stomach-related issues, unexplained diarrhea, vomiting. And if someone is experiencing such symptoms, expert advises getting tested or should get tested immediately. He should get tested immediately. This variant may not lead to any severe complication. That's to the solace of all of us, but can spread faster, and we have seen that. So nothing new. I'm just going step by step. I'll come to a very reliable report on this. And this is just a background. Therefore, early detection and isolation are extremely crucial, even now, even in India. So we have to be having precautions with the cold and crowds around. It is more crucial than ever to follow COVID appropriate behavior. At least mask can save us from particles, pollution, and variation of temperatures. If you're going to a very cold place, mask will be a little helpful. So wearing a mask, social distancing, and hand sanitization remain the basic steps, and then that can help prevent a possible spread. So one of the culprits which has now been identified, that those countries where the vaccines, I would definitely say Sputnik and Sinovac, but also proved beyond doubt is a Pfizer vaccine. And some of you must have seen an interview by the chief of Pfizer in the WTO conference when the media asked him, and he shunned all the questions. These were serious questions asked from the chief of Pfizer. So it is believed that low-level immunity due to previous infections can be one of the major reasons behind the surge in China. But I will put it like this, that decreased immunity because of inappropriate vaccination would be the main reason. And they have no data on this. Either they have data, they will not publish it. So currently, China, Japan, South Korea, France, United States have been reporting a lot of surge in COVID-19 cases, while we on certain days are reporting 0 cases, which is a very good thing, and it's something to be cheered about. Now, this is what we did today, and we have reached here. So before I go to the background of the topic, I would say the good news first. 26 January 2023, Prime Minister was to launch the COVID vaccine, but Health Minister, Mr. Mansukh Mandavia, and one of the more appropriate minister, like who is a doctor, Dr. Jitendra Singh, has been instrumental in introducing this to the Indian public, fixing the price 325 and 800 rupees for government and private hospitals, and would soon be rolled out for 18 plus population and as a booster. These are the two common permissions given by the Drug Control General of India and SATSCO. This is a better vaccine theory, intranasal SARS-CoV-2 vaccines, because they are likely to prevent infection and transmission and likely to prevent the disease. So both preventive and from one person who is suffering, transmission to the other person. So why nasal vaccine? Nasal mucosa has a lot of population of T cells and can produce a lot of immunity if exposed to antigen. So we have taken an antigen, and I would say next slide, what kind of antigen. And we have exposed nasal mucosa and safe exposed to antigen and triggers to produce immunity, because other nasal vaccines for influenza like influenza are available in US, already in use. So this is not a de novo experiment. So it is a well settled procedure, and stage 3 trials have been completed. So we are sure what we are doing and is correct what we are doing. So it's a needle-free method, non-invasive method, because of ease of administration, does not require trained healthcare workers like those who have to be trained about injections, how to give, where to give, how much to give, which needle to be used, how much amount of injectable material, how much they can discard, sort of. So the basic advantage is elimination of needle-associated risk, that is injuries and infection. Good compliance, ideally suits for children and adults. We would see when it will be rolled out for children. Now 18 plus we are talking. And we can do scalable manufacturing, able to meet global demand later on. And people were asking WHO's concurrence. I told them that we for ourselves have tested stage 3 trials and we have found it very safe. So we don't depend on WHO's saying yes or no to it. WHO has been delaying last time also COVID vaccines for mission, so we don't bother about it. And when we would have to send to other countries, if they need, WHO can jolly well give it. Now, intranasal vaccine for COVID-19 would be a very good facility for people. And we have taken a spike protein. We have involved 2 American institutions for this. And that is spike protein as is used in UK's Sarah Gilbert's vaccine, Covishield, and same adenovirus, common cold adenovirus is used, and the scientists tweak that the adenovirus rendering it unable to cause illness. So it's like live attenuated. Harmless adenovirus carries the spike protein to the nose, enabling the body to mount an immune defense against the SARS-CoV-2 virus without becoming sick. So good indication, good response. The name, as you have seen, is Incovac, and new vaccine also incorporates 2 mutations in the spike protein, and is presently, we can say, most conducive forms of antibodies against the existing strains what we have. So it will be effective as a booster dose, and it can be given to 18 plus. It can be mixed and matched. Additionally, researchers genetically modified the adenovirus to improve the production of spike protein. So this was the feature added to Incovac. And the most important aspect of Incovac is that it can easily be updated to keep pace with the mutations that virus undergoes. So we can switch it when we want it. Now, I'm going to present something which is very relevant, which encompasses all the things which we have gone through so far. In the COVID heart, patients have a lot of problems, and what we are seeing day to day is cardiovascular problems. So now we have to be serious about cardiac risks and post-COVID syndrome presenting with various cardiac complications or a delayed complication of COVID. And this is the largest study which I found, 154,000 cases at US Veterans Study of SARS-CoV-2. And this is a diagram, this is a cartoon which I always appreciated, that this virus has gripped the heart at the neck, like somebody is gripping my neck. I can't breathe, I can't speak. So this is a very, very informative cartoon which spells most of the dangers, and the background ECG also shows some P wave disturbances, some arrhythmias, irregular heartbeat. Of course, it's not capturing the ventricular serious arrhythmias which it causes before sudden death. So what we can say that from every angle, muscles, pericardium, and vessels, basically. So myocarditis, endocarditis, pericarditis, and vasculitis, that's coronary artery, and the conductive system, all are being grabbed. Jakro fight. Jakro is the right word in Hindi. Jakar leta hai corona hamare heart ko puri tarah se. And At the beginning of the pandemic, the research teams have identified and addressed the important knowledge gaps. You know, COVID-19, this is a very, very good writer, which I like this article. I would just adjust my pictures in this, and then I'll come back with a full screen. So at the beginning of the pandemic, the research team resolved to identify and address important knowledge gaps around COVID-19. And this Ziad Al-Ali told Jama in an email, this is a long email. I have some slides made out of that email, which are very, very informative. And if you can read that, what he found was that it's a long email. I have made a summary out of it. It's a veteran administration, St. Louis Heart Healthcare System, and is as a clinical epidemiologist at Washington University in St. Louis. That over several weeks, we started hearing about patients who were not fully recovering and had lingering issues, including heart issues, heart problems. And these patients who came themselves, as they called themselves, that long haulers, inspired the team to study long COVID, known as post-COVID conditions. In fact, I was talking at the end of the first year that it's the time we should always talk about the effects of COVID in the patient who has already suffered, and we should open post-COVID clinics. So all this I have been talking about. Dr. Agarwal, we lost, and I'm very sorry about his loss. I cannot. The last day he had a talk with me, in fact, on COVID. In a report, coming back, in a report published in Nature last April, the researchers demonstrated that people with long COVID can have sequelae in several organ systems, including cardiovascular disorders, which could be arrhythmia, sudden cardiac death, and so on. I will elaborate that. So with this study, I'm going to present, they set out to gain a deeper understanding of COVID-19 long-term side effects. I have summarized in this cartoon the effect, risks, and cardiovascular complications. The risk factors: old age, immunosuppressive diseases. We have been revising our lessons. So old age, immunosuppressive diseases, hypertension, CVD, obesity, renal abnormalities, multi-organ dysfunction, chronic respiratory disease, diabetes mellitus, coagulation aberrations, and tumor or cancer patients who are on cancer or who are cancer therapy. So cardiovascular complications, which we have seen in early part of the disease, was cytokine storms, causing death, causing patients on ventilator, going to the ventilator, systemic inflammation, like in children also, MISC, adults, myocardial infarction. Those were the times we could not identify these complications and pin them up. Heart failure, myocarditis, arrhythmias is still very important. Myocarditis is still very important. Myocardial injury is still very important. Sudden cardiac deaths, we have seen in many cases all over the world, and in India especially, some deaths have been caught in camera, some singers, some artists, some important people, some executives, somebody working in the gym, some comedian dying suddenly working at the gym. I would not name them because they were all very important people, and it's not to quote their names, I don't think it's proper. So overall, we can say thrombotic events and cardiotoxicity. If you remember these two ovals, I think this is the summary of my talk today. And the study, which I was talking, 153,000 cases, was designed in a foolproof manner. And they had, of course, more white male patients, less black and female patients. It's a VHA study, and is published in Nature Medicine also. It's published at various places. In fact, this is one of the most detailed monogram on this. And what we have learned, that patients with COVID-19 were at increased risk of a broad range of cardiovascular disorders, including cerebrovascular disorders. मतलब heart की बीमारियां होंगी, उसमें arrhythmias होंगे, sudden deaths होंगी, could be ischemic or with a normal heart. It could be pericarditis. myocarditis, sudden death, ventricular arrhythmias, ventricular fibrillation, ventricular flutter, ventricular tachycardia, and nobody can detect it. Soon the patient would collapse. So it's not a heart attack, it's a cardiac rhythm disorder. I have repeatedly said to the people that don't call it a heart attack, he died sudden cardiac death. This is a different entity in itself. It doesn't give us time. It doesn't give us time that patient you transport from the stage to the hospital emergency. Cath lab. No, it's not a heart attack. It was sudden cardiac death, which could be arrhythmia, which could be other causes of SCD, which could be a pre-existing condition leading to sudden cardiac death. So all this 12-month mark compared with contemporary control group, for every 1,000 people, COVID-19 was treated with an extra 45% incidence of pre-specified cardiovascular outcome and 23% incidence of major adverse cardiac events, MACE. Now, cardiovascular manifestation. What are the mechanisms, how it does take place? It's all ACE, majority controlled by ACE. I would tell where the ACE was not involved. It's a direct damage of the SARS-CoV-2 to the heart, downregulation of ACE2, microvascular dysfunction, capillary dysfunction, pericite injury, hypoxemia, leading to myocarditis, heart failure, and arrhythmia. These are the things which we should remember: myocarditis, heart failure, and arrhythmia. Now, there's another mechanism, another pathway. Release of cytokine, IL-6 mainly, there can be others. Hyperinflammation, very fast inflammation, leading to insulin resistance, coagulopathies, leading or clotting, both myocarditis, metabolic effect, thromboembolism. So this is also one side of the story, one picture of the conglomeration, one explanation, one possible explanation which we know today, but there was another study done by the very reliable institution, and they have found that fat of the body was taken from the people who have undergone gastric bypass surgeries or liposuction. The biopsies were done. And the virus was found embedded in the fat. Similarly, in the neurological tissues, the virus was found, and that was explaining the neurological complications, starting from brain fog to the stroke. Wide range. So cardiovascular, neurological, we initially thought it could be just brain fog. No, it could be brain stroke of any kind. Changes in the gray matter, changes in the white matter, neurons embedded, these virons embedded in the neurons. All these pictures were identified, and they were very reliable studies. Stanford University, you cannot doubt that scientists at Stanford have found out these evidences of the virus sitting into the fat. So the theory of ACE, receptors, is no more only theory. It lives in the whole body, it circulates in the whole body, it makes its nest or its permanent abode in the human body. And therefore, what we are seeing today as a complication of the COVID syndrome, or delayed COVID, or long haul, or long haulers, sudden deaths, neurological complication, memory loss, there are 200 complications which have been identified. It's not possible to name all of them. There could be starting from the root of the hair to the tip of the toe. So, incidence of dysrhythmias was about 20%, and out of which commonest arrhythmias was 10% atrial fibrillation. The other cardiovascular disorders, heart failure, non-ischemic cardiomyopathy, they were about 12 to 11 to 3%. And thromboembolic disorders, although in this study is 10%, but I think in Indian context, we can say it is more than 10, 12 to 15%. And ischemic heart disease, then a few acute coronary disease, sudden MI, incidence of myocardial infarction. These are the rough percentages. It's not useful to remember them, but 10 to 5 or 5 to 10, you can say, or 2.5 to 10 covers all these complications of cardiac complications. Then cerebrovascular complications, as I told, including stroke, 5% or 6%. Then inflammatory disease of heart, of pericarditis, myocarditis, pericardial effusion, I've seen pericardial effusion, I've seen cases of low ejection fraction suddenly coming after COVID, no disease, coronary angiogram normal, but less of cardiac function. So 35% ejection fraction, walking on the road, breathlessness, no obvious cause, and post-COVID. So this is the explanation given, that patients with more severe disease determined by whether they were recuperated at home or were hospitalized or were admitted to the intensive care unit had high risks. But the risks were evident even among those who were not hospitalized with COVID-19. And India has a very, very large population of those people who even did not have symptoms of COVID, but I find evidence later on in their chest or in their other tests, basic tests, they have suffered from subclinical COVID and they have made good immunity. What we have talked about, robust immunity in the past, that many of us have been exposed regardless of having COVID test positive or getting a COVID test done, which has been found positive. So the risks have increased. You have shown in Indian studies, CDOC has shown a study, the increase in diabetes by 7%, hypertension and cardiovascular disease roughly by 7%, risks associated with male sex, obesity, smoking, hypertension, diabetes, CKD, hyperlipidemia, and pre-existing cardiovascular disease. So all this we have to be careful about, and overall findings were consistent with the outcome that were compared between the patient with COVID-19 and control group in pandemic. Now, this is another a crowded diagram. I will make it more clear for my rendition. Yes, now. So, this is coronavirus. Viral invasion through the cell membrane goes inside, causes that cycle through the replication, viral polymerase, RNA replication. So this is how it multiplies within the cell. Okay. Here somehow we were told that remdesivir was acting. No, forget about that. It was not a good drug. Then we have two parts of this slide. One is pulmonary complication and second is cardiovascular complication. Now, pulmonary complications are cytokine storm mediated, IL-6, IL-7, IL-22, and other markers which were increased, like CXCL10. That all has led to the endothelial dysfunction of the vascular capillaries of the lungs, platelet activation, vasoconstriction, and vasodilator mediators, both oxidative stress leading to coagulation. Mind you, coronavirus has both the properties, procoagulant properties and anticoagulant properties. So it can lead to bleeding, it can lead to coagulation. So various mechanisms are involved, various mechanisms of the body are paralyzed. So both ways it works. It's a two-sided, two-edged sword. Now, as I said, cardiovascular complications, there could be an existing plaque which can rupture, causing acute coronary syndrome. There could be necrosis of the heart, acute myocardial infarction, as seen in the top cartoon on the right side, and leading to heart failure or sudden cardiac death. Then development of the clot, coagulopathy, acute cardiac arrest, and Kawasaki-like disease. That's a coronary artery embolism. So these are the broad representations. I've not included in this slide the brain manifestations. So because of some COVID-19 vaccines may be associated with rare causes, I've told now it's beyond doubt proved that the Pfizer vaccine is majority, it is named for immunity, which was 100% and 90%, 70%, 50%, and now doubtful. So the increased risk of myocarditis and pericarditis remain among the people who were not vaccinated and was evident regardless of the vaccination status. This is a very good rider. We should always say that the risk of myocarditis and pericarditis remained along the people who were not vaccinated and it was evident regardless of vaccination status. So why people are dying in West? Because either the immunity has gone down or they were not pro-vaccine. They were anti-vaxxers. So they had made a big group and they are now losing their lives. The surprise was that increased risks were most pronounced for the heart failure and atrial fibrillation, but the breadth of cardiovascular disease involvement was eye-opening. This writer, Ali, wrote in his email, the researchers also were surprised to see elevated risks for the people who were not hospitalized for COVID-19 during the acute phase, the segment that represents the majority of the people with SARS-CoV-2 infection. I would say here, like in India, I was saying, many people were not hospitalized and they stayed at home, but because of lockdown, they had very limited exposure. After the lockdown, they had exposure and they developed immunity. Okay. Now, similarly, a big population there also in these Western countries might have got exposed to the coronavirus and they might also have developed immunity. So their profiles were different. That is what he says further, that researchers were surprised to see elevated risk for the people who were not hospitalized for COVID-19 during the acute phase, the segment that represents the majority of people with SARS-CoV-2 infection. So either they suffered with COVID or developed immunity, or if they did not get exposed because of not being exposed to COVID, they are having the complications. Now, potential cardiovascular implications of the viruses in general are pericarditis, myocarditis, acute heart failure, acute coronary syndrome, and arrhythmias. Arrhythmias is very important for sudden cardiac death. Now, there is an overlap between hypertension, diabetes, and heart failure. And there were drugs which were taught initially, and I wrote a paper also in the very first few weeks that ACE inhibitors, if somebody is using, he should continue to use. It does not make any big change. So regardless of ACE2 and ACE2 upregulation, SARS-CoV-2 has caused myocardial injury and lung injury as shown in the previous slides. And this was the ACE2 based response. And now we are finding beyond this, as per Stanford's study, that it has been causing probably sudden cardiac death due to the leakage from the epicardial pad of fat or epicardial fat or extracardiac areas from which it can jump into the myocardium. This has been shown scientifically. And there's a whole article, 22nd September, there was the Stanford has published it. So the subgroup analysis also rendered surprising results. He went into the project thinking of the health issues could be evident among the people with high risk of cardiovascular disease, but the data showed that COVID-19 may be an equal opportunity offender. It continues to offend us, and he wrote the risk was evident in young people and old people, in black people, in the white people, in the males and in the females, and the people who smoke and the people who do not smoke, and the people who have diabetes and the people without diabetes. Very nicely written that everyone can be involved, and it did not spare any group. So there was a huge population that was affected, and we are here very proud to say that timely vaccination in such a big country, in such a big numbers, we have saved our population. So summing up, systemic inflammation, direct viral infection, going to the heart, lungs, blood vessels, anywhere in the body, through any of the mechanism, either through the ACE receptors or without ACE receptors, is a basic hallmark of the COVID was inflammation, inflammatory response mediated by cytokines, not only just a viral pneumonia or viral infection. And this has overlasting and everlasting, both overlasting and everlasting effects on the various cardiovascular organs and lungs, sometimes in kidneys, very rarely, and mostly before kidney on the brain. So central nervous system, cardiovascular system, respiratory system, and some other systems of the body, GIT. You know, it was initially isolated in one of the savages in Hong Kong. we have also seen sewage contamination very recently in India. So the complications in majority, cardiac injury causing acute mortality to about 50%, stroke incidence is 3%, mortality is less, myocardial infarction, great mortality, sudden cardiac death, sudden death, 10%, arrhythmia, very, very important, SCD, cause post-COVID, 44%, thromboembolism, nearly 30%, and direct viral infection is cause of all this through systemic inflammation. So I would say in summary that COVID has involved us, COVID has given us immunity. Now it is for us to identify post-COVID syndrome, residual manifestations of the COVID disease, keep evaluating your lung function, keep evaluating your cardiac function for every 6 months, go to the doctor. If you have reduction in saturation, I have seen after COVID of 5 weeks of ICU, I needed oxygen saturator at home. Now I have, after nearly 1 year, improved my oxygenation in the peripheral circulation, and now it is 98, 99. Otherwise, it stayed up to 96, 94, 96, 95, and I was working. So I did some breathing exercises, some pranayam. That's what I'm giving solutions. I'm giving solutions. So all of you should be careful, and we, the doctors, have to be very, very careful that we should identify and keep tracking those post-COVID complications if someone is having. And therefore, I would humbly say that I must finish my talk here. COVID has damaged our systems, and we should be very careful. And my humble homage and salutations to my dear friend Dr. KK, and I wish all prayers reach to him, and he must be in the best of the heavenly abode. Thank you very much.
So we have some live questions from our live audience. So it's
Okay.
in the chat box.
You read them out.
Sure, sir. So, sir, the first question is, what is the incubation period for COVID-19?
We have lately seen it was variable, 5 days to 21 days. Average was 14 days. It can vary depending upon your immunity, strain you have got infected, and the kind of infection, quantum of infection. So normally, if this was shorter, we could have identified many cases and saved many.
Thank you so much for answering that first question. Now, the second question is, sir, what are the major cardiac complications in the patients with COVID-19 and how often do they occur?
I have shown you percentage wise. The first complication in the heart is arrhythmias, because arrhythmias, you don't need to have any anatomical defect. Mostly half of the cases have atrial fibrillation, half of the cases have ventricular arrhythmia. The most fatal cardiac arrhythmia is ventricular flutter fibrillation and ventricular tachycardia. Most common ventricular tachycardia. Then pericarditis, myocarditis, endocarditis, vascular disease, acute coronary syndrome, MI, or on the other side, sudden cardiac death. These are the major complications. Then vascular embolism. Even I've seen the first case, pulmonary embolism, when we were not aware of COVID. The patient, the lady came with a leg thrombosis and lung pulmonary embolism. And I would call that also as a cardiovascular complication.
And so the third question is, what is multisystem inflammatory syndrome associated with COVID-19?
COVID-19 causes inflammatory cytokine to gush like a fountain in the blood, and IL-6, IL-12, IL-18, and other cytokines, they cause a cytokine storm. It is specifically seen in case of children that their multi-system gets involved, like kidneys, like lungs, like liver. So MISC, it is called multi-infection syndrome, or MISC for child. So in children, although we have very well protected our children with immunity, and still you don't have more pressure on the children to get vaccination. So even with this nasal vaccine, we have rolled it out for over 850. Children have got, I would say, good immunity. हमारे बच्चे जो है मिट्टी पे खेल के बड़े होते हैं, गांवों में हमारे बच्चे रेत में खेलते हैं, गड्ढे पानी में तैरते हैं, तो उनको इम्यूनिटी धूप में, छाँव में, सर्दी में, गर्मी में बहुत अच्छी हो जाती है. तो MISC stands for those who don't have good immunity, and they can get abnormal response to inflammatory response. And this is very serious complications. All these children have got MISC, they have been to ICU, but luckily in our country, not many children have died, or just the maximum incidence which was worked out by Indian Council of Pediatrics. I see Indian Council of Pediatrics was 1% childhood deaths. So, but this is an hyper immune inflammatory response.
Thank you, sir. And the last question is, when are antiviral treatment, glucocorticoid, and other COVID-19 specific therapies indicated?
You know, the indications of, I have jokingly referred at one place, remdesivir. You see, we did not know anything about COVID. We are still learning. Now we are through from that phase. What we have to deal is now only give symptomatic treatment. If somebody's COVID test is positive, saturation is fine, no need to give steroids. No need to give anti-inflammatory drug. No need to fight for drugs like remdesivir, which are already away from the shelves. Now, one thing very important, that antibodies, role of antibodies. Previously, we have seen that role of antibodies was there in a few strains, before this new strain came, Omicron, and Omicron was notorious to defy those antibodies. So we have made antibodies in India, and now it will depend on the strains which we will identify. INSACOG is actively isolating in positive cases, and now a new generation of antibody therapy shall come. So sans steroids, sans old antibodies, we will have newer antibodies and newer vaccine, which could be like wide spectrum vaccine plus wide spectrum antibodies in future. Presently, we don't need to treat these cases with either antibodies or hyperimmune plasma or drugs like remdesivir, which was sold in black in the past. So we have passed that phase. So now we have to just symptomatically treat, isolate, and I will finish the answer because it's the last question. Do not forget the basic COVID appropriate behavior, distancing and masking and sanitization. We should not forget. So all of this combined, we can have, despite COVID cases are flourishing all over the world, I pray sincerely that our immunity remains intact, and we should prevent ourselves from any further outbreak in our country. For that, we should mind our travel, we should mind our going out in the crowd, we should mind children going to the school without properly being vaccinated, and so on. So protect yourselves, and that's the best option. We will remain with COVID for the rest of the years, and COVID would be part of our life. So don't scare this. Treat it like as a common viral illness, influenza-like illness, but the preventions should be followed vigorously. Thank you very much.
Thank you, sir.